It's great to be here with you today, and I'm going to talk a little bit about using AI in the context of gerontology, which is the area of research that I'm engaged in. Given that there's a lot of excitement about what AI can possibly do to help us all age in place, stay independent, and the residents of our choice for as long as possible. So a lot of the work I'm presenting fits within the context of precision medicine, because in precision medicine, we talk about collecting and analyzing large data for an individual to understand not only how they present themselves during a clinical encounter in terms of their physiology, but also the place they live, how they behave, where they work, their lifestyle, their genetics, and the environment they find themselves in. So better understanding the individual in all those aspects is something that calls for more personalized understanding, treatment, diagnosis, and treatment. And here's where behavioral sensing can play a significant role. And when I talk about behavioral sensing, I'm mostly referring to passive monitoring and wearable technologies. And with passive monitoring, the anticipation that this could play a role with older adults is that a lot of times these technologies are in the background, so you don't have to learn to operate new hardware or software, which could be challenging for people who are experiencing cognitive decline, visual impairment, or have not had the same level of digital literacy as other individuals may. And so the goal with all these technologies is to ultimately, objectively, remotely, and continuously measure aspects of the patient's physiology, behaviors, and symptoms. So we're hoping to capture behaviors and activities of daily living without having human observers, which would be very costly to do in the real world, and also without relying on self-report, which we also know brings its own set of challenges. And oftentimes, when you look at the literature, we find that people tend to over or underreport, for example, how much they exercised or how many hours they slept. Furthermore, with these types of technologies, we can shift from episodic to continuous monitoring, and also in the real world rather than in a laboratory. So going back to the example of sleep, if you have had a sleep study in a sleep center, you're asked to sleep in a different bed in a laboratory wired with a lot of cables, with video and audio settings hanging from the ceiling. So it's a very different setting, and you would sleep very differently than how you would in your own bed. Ultimately, the goal with all these technologies is to shift from a reactive model to a more proactive model. So right now, unfortunately, we're waiting for an adverse event to happen, whether it's a fall, a hospitalization, heart attack, and then trying to minimize the impact of that event. But in many cases, understanding what's going on in people's lives can give us data that can facilitate a more proactive approach so that the actual adverse event does not happen. So with smart homes, we see that potential of using passive sensing to better understand what's going on in people's lives. And broadly defined, a smart home is a residence that is equipped with the right infrastructure to passively monitor the individual's activities of daily living with the goal to enhance their safety, independence, and well-being. So one of the examples I wanted to showcase where we used AI in a smart home setting is an intervention we call Sense for Safety. This is an initiative that was funded by the National Institute on Aging and the Centers for Disease Control. And here we're looking at using technology to facilitate a fall prevention intervention, specifically targeting older adults who are socially vulnerable with mild cognitive impairment. So why are we looking at falls? For those of you who are doing aging work or have aging relatives, you know that falls is a critical challenge in gerontology. And they are the result of accumulated vulnerabilities. We're looking at cognitive impairment because that's a leading risk factor, and people with mild cognitive impairment are at a much higher risk of falling annually than their counterparts without cognitive impairment. And similarly, residential settings and neighborhoods can affect your risk for falling. And socially vulnerable older adults who live in low-income neighborhoods are much more likely to experience a fall than their counterparts who live in other neighborhoods. So in this project, we're using depth sensors, where the idea is that we install this in people's homes. We installed the depth sensor in the living room so we can capture a full gait, understand how people walk every day, but then with machine learning, we're learning to tailor and calculate the individual's fall risk score. There's a coach who meets with the older adult every 2 weeks, and they go over those gait data. They talk about the fall risk, and then also promote an exercise and home modification intervention. We're using an exercise protocol called the Otago exercise. It's an exercise program that has been tested for people with dementia, people with very limited mobility. And similarly, home modification can be low-cost fixes that could improve lighting, remove loose objects from the floor to increase people's safety. The goal here is to reduce the individual's fall risk score. So depth sensors create silhouette extractions that allow us to extract information about gait speed, stride length, balance, characteristics that are being used to calculate that individual's fall risk score. So in a way, it's more privacy preserving, if you will, because we're not using video images, and we're ultimately not storing those silhouette extraction images either, but are interested in the gait data that can help us calculate those fall risk scores. Of course, if a fall does happen in the area where the depth sensor is installed, the system does detect it, and our coach gets an email, a notification with the last 10 seconds of the video, so they can confirm if it is a true positive, indeed the person has fallen, versus a false positive where they purposefully sat on the floor or they dropped a large object, and so they can accordingly initiate a response protocol. However, our study focuses on fall prevention, not fall detection, and I emphasize that because we're not placing sensors in all parts of the home, only in one area where we can capture gait data. A lot of falls happen in the bathroom or in the bedroom where we don't have depth sensors, and of course a lot of falls happen outside the home as well, and we are only tracking things that are happening in the home. In this study, we used 90 people who had the technology for 1 year in their home. They were all community-dwelling older adults over the age of 65 with mild cognitive impairment who lived in low-income housing. And one of the findings we found that is pretty encouraging is that we had a human expert, a clinician, visit our participants every 3 months to perform an assessment based on their expertise, what's called the Short Physical Performance Battery, which is a series of tests that capture information about lower extremity functioning. And so they're asking people to sit down, get up, walk, and they're timing them, they're observing them, and provide that total score. What we found was that with our technology, the system was estimating those scores with very high correlation to the human assessment. In other words, we could rely on the technology to accurately capture the SPPB scores for these individuals. And that is important in terms of understanding the person's fall risk. So here you can see examples of 3 different participants with different scores. The first on the left is a person with a low score, which means that they are experiencing significant difficulties in ambulation. The person in the middle has a mid-range score, which means they're experiencing some difficulties. And the person on the right has a high score, little or no difficulties in moving around and ambulating. So we can have a relatively low-cost approach to detecting how people are functioning in their home, and more importantly, if they're changing categories, they're shifting from one to another, which increases the risk for falling, in a way that is done passively and continuously. And that can be really important because our population does not actually have access to a fall clinic or a physical therapy expert who would be performing those types of assessments regularly. As a matter of fact, most older adults don't have access to these services unless they have already experienced a fall and in many cases have been hospitalized for that fall. So in this case, we could use the system in a more proactive way where hopefully the fall does not happen because by early detection of when scores change, you can intervene and in many cases keep people safe at home. One of the things we were interested in this study to do was not just to have the sensors collect data about people, but actually find ways to visualize that data and make it accessible to our own participants in a way that would hopefully engage them and also provide them meaningful and actionable information. So we did a series of focus groups and interviews with older adults, family members, clinicians, to try and figure out how to best visualize gait data. And that's not an easy task for many reasons, one of which is that gait data are not as intuitive as other clinical data like blood pressure or weight, where you kind of know higher may be worse, lower may be better. This is an example of the clinician dashboard, so this is what our coach sees. For each individual participant, they can look at gait characteristics like stride length, average speed, stride time, and so forth. And they can also annotate these data sets based on information that's clinically relevant. And this is an example of the dashboard we use for older adults. After a lot of focus groups and iterations, we came up with a dashboard that's still not that intuitive and still not necessarily user-friendly. As a matter of fact, many of our participants love their dashboard and look at the data religiously every day, but we also have a lot of participants who never look at the dashboard or who will often say, I want somebody else to look at this, my clinician, my family, but not me. And this is where, when we think of designing these types of systems, and also as we think about integrating AI into systems for older adults, we have to recognize that in many cases we're designing for a diet rather than for an individual user because of the informal caregiver or the family member, or as we call them in this study, the trusted other, who plays a significant role as a proxy decision maker and also as a member of the disease management process. We use the term trusted other here because we often had participants who chose a neighbor or a friend rather than a family member to be the recipient of the data. And people in our study found that it was important to be included. The alerts were seen as providing peace of mind, and also they were critical in working with the coach to reinforce environmental modifications and exercise recommendations. So as we think about monitoring technologies that use AI in the home, a lot of times the argument is made that when it comes to passive sensing or ambient listening or voice-based generative AI tools and conversational agents, that those are not obtrusive because you don't really require the user to receive training in using the technology. However, we argue that obtrusiveness is a much more complex term that doesn't only pertain to user-friendliness of the system or the system's interface, but rather is a summary evaluation based on characteristics or effects that are associated with the technology that are perceived as undesirable and physically or psychologically prominent. And what that means with this definition is that obtrusiveness is something subjective. So some technology that may be obtrusive to me may not be obtrusive to you. And I might be willing to accept certain types of monitoring technologies that you wouldn't. And this has been well documented when we talk about faults where perceived need oftentimes ameliorates privacy concerns. In the geriatric literature, there is a term called long lie, which is when older adults have fallen and remain on the floor undetected for more than 2 minutes. And those tend to be the types of faults that have the most severe health consequences. People who have experienced a long lie are consistently more open to the idea of intrusive monitoring, even having a video camera in their own bedroom, because they don't want to relive that experience, which is something that perhaps a younger, fit, independent individual would not necessarily welcome. So again, obtrusiveness is defined by the users themselves in the context they find themselves in. And it also includes multiple dimensions. There's the physical dimension of the technology itself and how it works and operates into the home. Some of the older smart home applications would have sensors hanging from the ceiling or cables in order for that equipment to operate. And so how that may obstruct their personal space or may be aesthetically incongruent is part of this obtrusiveness assessment. When it comes to interfaces and how people interact with these technologies, there is the aspect of usability. We talk a lot about privacy, but in addition to the technical specifications for privacy, such as encryption and password protection, privacy is also how individuals perceive the violation of their own private space. So even if we have a pretty secure system, if people feel like they're being monitored or watched in an unwanted way, that does violate their privacy. We have to address how technology operates and whether it's reliable. With the use of AI, a lot of times our systems are black boxes to the user, so they don't necessarily know if they can trust them and how reliable those systems may be. A lot of the concerns raised when introducing systems that do this type of monitoring have to do with how those may impact human interactions and whether, for example, using a system that provides this type of remote monitoring would lead to the nurse visiting less often or family checking on one through the portal rather than visiting, or what that may mean in terms of relationships with friends and neighbors. How people perceive themselves when they're being monitored and whether that's linked to a symbol of loss of independence or whether it could be stigmatizing. And again, in the fall literature, we see in the early days people who would not wear fall detection devices or alerts because of the stigmatizing aspect of it. How the technology is being integrated into daily routine, and then the question about whether people can actually sustain the long-term use of the technology. They may learn to rely on a technology that they might perhaps not be able to afford in the future, or they may not be able to sustain its use. One of the feedback we have received when we came to visualizing the gait data had to do with creating some type of chatbot where the system would summarize what is going on with people's gait and overall well-being. Many participants would say, well, couldn't somebody like Alexa summarize in a couple of sentences what this data mean? And indeed, we see generative AI playing a bigger role in gerontology. It's anticipated to actually, just like in other cases of medicine, support clinical decision-making. But what's really important with generative AI in the space of aging is also the fact that you can tailor the communication to an individual's cognitive levels. And many times people might be experiencing cognitive decline, especially in the field of dementia care. There's concerns about repetitive questioning or how to best communicate with people with dementia. And so generative AI applications could potentially address this and provide even companionship for people who are socially isolated or lonely, increase access to material where we can tailor the material based on the individual's preferences for language and digital literacy, and then obviously documenting care transitions. Older adults who are experiencing a lot of transitions in care sometimes move from one side to another that are not part of the same network and have to repeat their medical history, have to provide the same information, and somehow we rely on the informal caregivers to capture and document all this related data and information that's critical for those transitions of care. And we already heard from our previous speaker how ChatGPT can be used not only for clinical decision-making, but also for patient education and communication with patients. Another study that was published 2 years ago when comparing physicians' responses to patient-generated questions to ChatGPT's responses, rated by an independent expert panel who were not aware as to who provided what response, they consistently rated the chatbot's responses as higher in quality and higher in empathy than those of the physicians. And partly that is obviously because we don't know the exact conditions of this study. Perhaps they asked physicians during their lunch break and they briefly responded to the question versus ChatGPT that might take 20 pages to answer the question. But also potentially ChatGPT's ability to convey empathy during these communications in a way that perhaps cannot be easily captured in a very brief communication with a healthcare provider, especially when you look at the data where we spend less than 7 minutes with our primary care provider. So that doesn't necessarily leave a lot of time to meaningfully answer a lot of questions. So I wanted to briefly mention another project that we have been involved in that looks at social isolation and loneliness for older adults. And this originally started during COVID as a project looking at social isolation, specifically because older adults were experiencing this more so than any other segment of the population. If you remember, with the social distancing rules, people in retirement communities and assisted living facilities globally, not just in the US, were not allowed to have visitors, and oftentimes they couldn't even interact with staff. But over the years, we pivoted to include social isolation and loneliness more broadly, not only pandemic related, because that is a challenge that is observed at higher rates for people over the age of 65. And so in a team with the US, in partnership with my colleague, Dr. Insap Lee at the School of Engineering, and then a team of collaborators at Osaka University, we launched a study that tried to look at how we can tailor interventions for social isolation and loneliness. So again, similar to the previous example, we use smart home technologies. Here we just use commercially available motion sensors, door and window sensors, bed sensors to capture information about activities of daily living. How much time are people spending inside their home versus outside? How well are they sleeping? How active are they within their home? How sedentary? And we installed this in 2 different communities, one in West Philadelphia and one in Japan in Ikoma City. So we had one large group that we followed longitudinally for 6 months. We installed the sensors in those 2 communities that monitored motion, proximity, temperature, television viewing, sleep quality, and physical activity. And overall, people were very accepting of the technology and were actually open to having this type of monitoring. They specifically expressed interest in participating and recognizing that they had trust in the academic partners, that they wouldn't necessarily feel comfortable sharing data with a third party that they would know, but because they trusted the entities involved, they felt that this could be beneficial. They also saw benefits in receiving more information about their loneliness and social isolation, and figuring out how to improve healthy behaviors and address ways to improve their quality of life. Of course, they had concerns if the sensors would accurately capture what's going on, if they would always be accurate, and again, if there would be a human response in response to what the data are really capturing. So the next step, once we started seeing that the sensors were providing meaningful information, was to think about developing an AI chatbot that would actually summarize this data for the participants, but also perform a daily check-in, engage in Q&A, but also some aspects of companionship. So the idea was not that they would necessarily be a virtual friend, but rather that they would say, it looks like you haven't slept well the last few days, or it looks like you haven't left your apartment, and then do some problem solving about whether something could be done to mitigate that. Would you feel like you should take a walk or call a friend to go to the store and so forth? So obviously, as you can imagine, with everything we read in the media about mental health chatbots, there was a concern having a population that is specifically labeled as isolated and also reporting high levels of loneliness, in terms of how inappropriate at times those conversations may end up being. So our computer scientists ensure to include guardrails to prevent inappropriate interactions. Given that suicidal ideation is such a significant concern, and there were all these really negative examples of how different chatbots did not successfully address suicidal ideation, or in some cases completely inappropriately exacerbated the risk based on inappropriate content and communication, that was a very big concern of ours to ensure that we have safety improvements with ways to filter sensitive topics, and to ensure that those conversation agents don't become a mental health coach, but rather an interface that summarizes the sensor data. In another study we had done with embodied conversational agents, we addressed some similar challenges. So with embodied conversational agents, we're talking about systems that in addition to interacting, they're using both verbal and non-verbal cues, such as prosody and movements or gestures. They can be anthropomorphic, or they can be avatars, they can be digital pets. But in gerontology, while those are being thought of as promising tools, we don't have a large number of studies that have tested these technologies, and in many cases, they've only been tested for feasibility in a laboratory setting. We don't really know how people react to those tools longitudinally, and also a lot of these systems have been focusing only on one aspect, such as medication reminders. So we wanted to examine the feasibility of embodied conversational agents in real-world settings over a longer period of time, and look at a system that would be more comprehensive as a conversational agent, not only focusing on reminders or just collecting information. So we did a 3-month evaluation study of an existing commercially available digital companionship device, and again recruited community-dwelling older adults with mild cognitive impairment. The product we used is a virtual pet that's displayed on a tablet by a company called CareCoach. So the participants could choose if they want a cat or a dog, they would name it. And the avatar would interact through voice, but also would be able to pull up pictures, send reminders and prompts, use pictures and multimedia. At the other end, there was a portal where family members and clinicians could enter specific health information, such as make sure to remind the participant to take their medication every day, or also information about likes and dislikes of the participant in order to make that information more tailored and more personalized. So our participants really were excited about participating in the study because they were motivated to explore. They liked the interactive aspect of this type of technology, and also that it felt like a game or with a surprise element. Once they started interacting with a conversational agent, they really enjoyed the idea of having somebody who would check on their well-being, who would often initiate the interactions, who would send friendly notes and messages, and also the fact that the agent would remember things and personalize the communication, would display images or bring up information that was specific to that user. But on the other hand, many participants talked about this not being a three-dimensional object. We talked about a virtual pet, but it wasn't really a pet that they could hug. And communication was at times problematic. The vocabulary was limited. The pet was repetitious in its questions, and in some cases, it was interrupting at inappropriate times. The system was set up so that it could initiate conversation, not only speak when it's spoken to, so in many cases it would start asking questions in the middle of the day when people would take a nap or have a visitor. And then one other interesting thing we found was that sometimes the pet would start interacting in a way that in gerontology we often refer as displaying ageist bias. When you use baby talk, when you refer to an older adult as grandma or grandpa, or when you infantilize your conversation partner. And that happened a few times. And I think it's interesting because we have focused on bias in our training data when it comes to racial or gender bias. And we haven't seen as many studies around ageism in training data, but I think it was clear in this conversation that the digital pet was oftentimes switching to a certain way of talking that would no longer be acceptable for healthcare providers, for example, in a community setting. So when we think about integrating AI for behavioral health specifically in gerontology, we have to address the aspect of ageism and the fact that we often have systems that are being designed without the active input from the real true end users. We did a literature review, a scoping review of AI and aging, and found thousands of studies, but very few specifically described stakeholder engagement or having older adults and their family members included in the design phase. As people use these tools for mental health and to share the most private aspects of their lives, we always have to address the concern of privacy, especially as we think about generative AI that's being used more and more in reminiscence therapy. So reminiscence therapy is a way to actually provide pleasant experience for older adults by talking about past experiences that they found enjoyable. It can include having people listen to their favorite music, talk about newspapers from a favorite time, and then talk about family, friends from that time, as well as experiences. A lot of times people open up and disclose a lot of private and sensitive information during these sessions. I've already mentioned the issue of bias and also the data quality when it comes to how those systems are being trained. The role of family is crucial because a lot of times when we come up with new systems, we really are asking the family members to take the burden of training or adapting the technology or ensuring that the infrastructure is there to ensure that the technology operates as intended. And then finally, because some of the work I do is in the space of dementia, I wanted to talk about the need to redefine the consent process. We oftentimes talk about consent in research as the event of having somebody sign the consent form, which really now calls us to rethink and define consent as a process rather than an event, because a lot of times people don't necessarily know what they're signing up for, and we may not know ourselves how to fully explain the risks and benefits. We may not know the risks ourselves in terms of unintended consequences for a lot of these systems, and especially how to explain them to people who might be experiencing cognitive decline and might not have a lot of previous experience with any types of technologies. Finally, I just want to wrap up by mentioning that we have an initiative at Penn funded by the National Institute on Aging called Penn AI Tech, which is the Artificial Intelligence and Technology Collaboratory for Healthy Aging. That's an initiative that's funded by the National Institute on Aging, and it basically is a national pilot competition program where we fund pilot studies that use AI to promote aging and also improve the lives of people with Alzheimer's disease and related dementias and their families. So each year we fund anywhere from 9 to 12, sometimes 10 or 15 pilot projects. We've already in the past 5 years have funded 54 projects. And so if any of you are interested in exploring the use of AI specifically for aging and have an idea that you think can be ultimately impactful and change people's lives, please visit our website to learn more about the program. We have seen a lot of technologies ranging from medication adherence, conversational agents, decision support during primary care, voice interfaces to detect cognitive decline based on voice, biology of aging applications. And that big, broad spectrum highlights that AI can indeed play a significant role in improving care and quality of life for older adults. So I think now we are at a unique opportunity to harness that potential, but also set the right boundaries in terms of what the appropriate use and the responsible use of AI should be in gerontology. Sometimes the clinical and the ethical and legal implications come after the technological advancements, and oftentimes we feel like we are trying to catch up by what technology can do. This is a unique opportunity to actually define the parameters that we want to set for AI to have the maximum positive impact on life and quality of life for older adults. So with that, thank you for your attention, and I'd be happy to answer any questions.
Hi, that was very interesting. One of the things that caught my attention was when you said the pet thing, that they were infantilizing the voices. Do you have any guesses as what was prompting that, or if there's anything about those specific patient populations or the way they converse that prompted the models to display that behavior?
So I would say, and this is my guess, is that this phenomenon of infantilizing older adults is not new, and there is literature, even in training manuals from the 50s, where healthcare professionals were instructed to refer to older adults as sweetie or grandma, and there is material even in nursing curricula from older times that are using that type of language. I think the idea at the time was that you are becoming more approachable or more nurturing towards the older adult. So my guess would be that it's somewhere in the training data. It's dialogues or instructions that are carrying that bias.
So thank you for the wonderful talk, and just had a question about implementation. So thinking about like the payment models and funding models for these tools to get deployed into practice, like do you see these as tools that are so useful that patients or their families pay for them? Do you see them as things that be covered by insurance or paid for by some other entity, or who would pay for the implementation of a lot of these tools?
Yeah, that's a great question. I think ultimately all this work can be great as a theoretical exercise, but unless it translates into the real world, it's really not that productive. And translation in the real world means reimbursement. I think for different types of technologies, as long as you have some evidence, it can be integrated into models of care. So for example, the fall prevention example, if we can demonstrate, and we're currently carrying a clinical trial where people are randomly assigned to the intervention or standard care. So if we were to show that for a certain segment of the population, we are reducing the number of falls by X%, that could be significant cost savings. So in those cases, I would think home care agencies or even health systems might be interested in reimbursement. At the earlier days of work in social isolation and loneliness, that was not an area that was very likely to get reimbursed because it was considered less immediate, clinically urgent topic. But now, especially with more recent reports from the National Academy of Medicine, we know that those are linked to worse clinical outcomes. Actually, they say loneliness is worse than smoking 10 packets of cigarettes every day. So I can see interest for reimbursement if, again, we have a solid evidence base that this improves certain health outcomes. So in the state of New York, there's a robotic conversational agent called EliQ. It's commercially available. And CMS is doing a big demonstration project, installing this in people's homes who are isolated and live alone. And they're tracking outcomes to see if potentially they would be providing reimbursement. So I think we'll see an initial slow adjustment, just like with home telehealth, where in the earlier days, we were excited about, hey, we can measure and collect data from home, but there was no reimbursement for that until we had enough evidence that this is actually improving plans of care. So similarly with a lot of those AI tools and home monitoring, more sophisticated home monitoring, I do think ultimately reimbursement will be addressed once we have more solid evidence of the outcomes.
Thank you. It was very insightful information. Thank you for sharing.
Thank you.
My question is that as we know that the population is aging in every society, particularly for the people who are the Alzheimer or the dementia, it is very, very challenging. So my question is, would it not be a good idea or a better approach if we use the humanized, the robotic humans as the companion for the people who are living lonely, because they are the ones who are the most vulnerable. In Japan alone, I think 30 to 40,000 people die because of loneliness.
Yeah.
College, no one can report it, no one can notice it. So what is your take?
I think this is a really great point. I do think that we need to tackle these challenges with different technologies, and potentially not one solution or one tool would be the solution for all. I definitely think humanoid robotics has a great potential. I know in Japan it's also being used for actual caregiving tasks, like transporting patients from the bed to the bathtub, which is something that in other countries leads to a lot of accidents by healthcare workers and caregivers. So it can be use of robotics for manual tasks, but then also humanoids for companionship. Some of these developments call for us to rethink some of our ethical and clinical guidelines currently in terms of thinking of new solutions that potentially seem at first unusual or foreign to more traditional decision makers in the clinical space. So I think there is still some resistance about how much of a humanoid or a virtual friend should be integrated in formal plans of care. But given how the technology is advancing and how many other countries are adopting this, I think it will become a matter of when and how rather than if.
Yes, I'm wondering if there was an ability to use other languages, first part. And second part is, you mentioned in one of the studies, it was asking for activities of daily living. So do you use those longitudinally to assess like cognition and depression as well? That was my question as well.
Yeah, absolutely. So for the first part of your question, I do think that being able to generate output in different languages will have a huge potential for being more inclusive in system design. In our work, we have not used any chatbots or other conversational agents in languages other than English. But given how the technology now affords us to do that in multiple languages, I think it's the next step, and it definitely will allow for more inclusion. And then in terms of longitudinal observation, yes, there's already studies that show how overall activity levels and mobility are linked to depression. We see that even anecdotally, I should say anecdotally or empirically, because we have smaller sample sizes than perhaps what would be necessary to demonstrate strong correlations. But we see in our participants, people who do report that they're depressed tend to also spend more time inside, more time in bed. We have, for our cohorts, periodic assessment of social isolation, loneliness, depression, anxiety, and overall quality of life, in addition to some physiological parameters. So obviously, there is also a lot of literature from other research groups around so-called life space, namely the more you move outside of the center of your home, the more likely you are to be less depressed and perform better in physical outcomes of health, versus the more time you spend in a smaller life space, the more likely you are to experience negative health outcomes.